Hi everyone. Thank you very much for coming today to our session 4 of Evidence into Practice, our luncheon series on health econ. Today we have Dr. Chris McCabe, who's going to give us a presentation. And just if you hadn't had a chance to print off your PowerPoints, we will have a bunch of them printed off and we'll just disperse them as he's starting. So don't worry about that. Okay, Dr. McCabe.
Thank you very much. Thank you. Good afternoon, everyone. It's good to be back. I was being told that you got a bus here, and so I think it's the first time people have ever got a bus to come and see me. So I feel it makes me feel almost important, almost. So today I'm going to talk to you about decision analytic modelling. So the official title is Vehicles for Undertaking Economic Evaluation, but for reasons that I'll explain in a moment or two, that always ends up being a model. If it's not a model, you're probably doing something wrong. It may be well-intentioned, it may be technically beautiful, but it's almost certainly wrong. So I'll talk about that. I've pitched the content on the slides at a reasonably accessing sort of early level of expertise. I don't have a great sense of what the level of expertise in the room is. If people want to ask more technical questions, feel free. You know, we can get as complex as you need it to be within the time constraints that we've got. So if there's specific issues that you're coming here today hoping to get some help with or some insight on, at the right moment, stick your hand up, ask a question, and then if that doesn't work, we've got a bit of time left for questions at the end. Okay, so what am I going to talk about today? I'm going to talk, well, why model? Why do we bother with this thing called modeling? And then, what is a model? Talk briefly about designing a cost-effectiveness model, what you need to think about. And then I'm going to talk in a little more detail about the two workhorses of models for economic evaluation of health technologies, the decision tree and the Markov model. And I'm going to give you, some guidance about when you should use which. And then I'm going to give some health warnings, reasons to be cautious, okay? And then I'll summarize that. Hopefully, I'll manage to get through all of that and still have 10, 15 minutes left for questions, but we'll see how things go. Okay, so this is one of my go-to papers. It's very old, back in 1956. The magical number 7 plus or minus 2. Limits on our capacity for processing information. Basically, this is the classic paper that demonstrates that we as human beings can't actually hold that much information in our heads and process it well. The very best of us can maybe hold 9 pieces of information. Most of us are somewhere around 7. And as time passes, I'm feeling more and more comfortable with being a 5. If you think of any decision that comes across your desk to do with healthcare resource allocation, if you can find one that has kind of less than 9 pieces of information in play, then I'm impressed, because whenever I think about the decisions we have lots more information than 9 pieces of information. And models are a way of getting control of that information so that we don't use the heuristics, those shortcuts that we've developed to navigate the world, but actually sometimes can lead us very wrong. If we use a model, construct a model, program it into the computer, that's our defense against inadvertent use of heuristics, which can lead us into really big mistakes. Okay? So the first reason for why model is because we can't do it in our heads, and we shouldn't try. I know we're often tempted, especially when we think we're experts, but actually there are really quite tight limits on our ability to process information. Here's a bunch of other reasons why we would model when we're trying to inform a decision. right at the top, all the relevant evidence is not contained in a single trial. Okay, so again, under what circumstances would we believe that a single trial contains all the relevant evidence for our decision? Not for testing a hypothesis, which I talked about last time, but for the decision we've got to make. They're not likely to be particularly representative of the patient group we're really dealing with. The protocolized nature of care around the intervention in the trial is probably not like what happens in day-to-day practice. The comparator may be completely different. It may not, the trial may be placebo-controlled. So almost never will you get all the information that's relevant to your decision in a single trial. I've gone to list a few of these reasons why. So patients participating are atypical, quite often because the outcomes we're interested in actually are very long-term outcomes. In a trial, we collect intermediate outcomes. So how much the cholesterol, the LDL, the HDL is changed. And we use that to predict the cardiovascular events, which is what we're really interested in. But that prediction is a model. The comparators are often different. The subgroups are not necessarily the ones we're interested in. Increasingly, those of you who are dealing with really quite, the expensive novel technologies that our lovely drug regulators are waving through enthusiastically, will be dealing with designs of trials that actually do not give us direct, unbiased estimates of the effect of the technology we're interested in. These crossover designs, treatment switching, actually plays hell with the estimate of the effect of what we expect to see in practice. So that's really problematic. And almost always, the costs and the benefits that we're interested in extend beyond the trial follow-up. So a fantastic new treatment that saves lives means that there's people who are, I'm glad to say, alive using our healthcare system under the new treatment. Those additional costs for that healthcare needs to be taken account of because it is a direct impact of the new technology. The trial won't tell you that. So we're almost always going to need to model. An economic evaluation alongside a clinical trial is interesting, but very rarely, in fact, in my experience, never actually speaks to the decision that the health system faces. So that's a problem. So we're always going to end up modeling in order to address the decision problem that we have. So what is a cost-effectiveness model? Well, here's a reasonably well-used definition from the beginning of this century. So first and foremost, it's a systematic approach to decision-making under conditions of uncertainty, in which the probability of each possible event with the consequences of those events is explicitly stated. So the key words, systematic, uncertain, and interested in consequences of alternative action. So it's incremental. So when we're using models for economic evaluation, we're comparing at least two different courses of action. Does the model have to capture reality? Warts and all? Well, no, models are abstractions of reality. Randomized controlled trials are models. They're abstractions of reality. The question is, in that abstraction, do you lose anything important? An important determinant of cost and an important determinant of outcome? Or are the things that you choose not to model peripheral? That judgment about, could this factor actually change the decision? If we incorporated it, would it lead to a result that said we shouldn't pay for this, whereas the model we currently have is saying we should, or vice versa? And that's a judgment, and it's one of the key challenges for the analyst, to engage with the decision maker in that discussion, because the decision maker has to believe that you've not missed anything important out. and often not just the decision maker, but other stakeholders. So if the clinical community don't recognize the clinical pathway that's in your model, they will completely ignore the results and they won't engage. So your model has to be enough like reality that the stakeholders in the decision process believe it and accept the results as meaningful. But if you try and model everything, A, you'll run out of time, because I've noticed that decision makers want information rapidly, and the more complex you make your model, the longer it takes. So you'll run out of time, and the reality is you will start using more and more uncertain evidence as well. As you expand it so that it looks so much like reality, it is reality, actually there isn't good evidence for lots of the things, there's just anecdote for a lot of things. So you actually start introducing uncertainty and potentially bias into your model. It's a judgment. You need to think about the evidence base. You need to think about, pragmatically, your computing limits. Can you actually build this and run this and get results out that are meaningful? And your user sophistication. Now, there is a view that says, actually, as long as the analysts believe and understand the model and know that it's right, the user should take that on trust. So whenever I get on a plane, I trust that the engineers have designed a plane that flies. I don't ask anyone to explain to me how it flies. And so shouldn't we take the same approach with modeling? Life would be nice if we did, but unfortunately we're dealing with very intelligent communities as stakeholders in these decisions, and they want to understand it. And so if you can't explain your model at a level that your users, your stakeholders in the decision can understand, then your model is not going to be as useful because they're going to reject it. And so you have to take account of your user sophistication. Don't do a complex model just because you can. Much as it's great fun to show off how technically able we are, being able to do it is not a good reason for a modeler to do it. 3 days ago, I was looking at a model that underneath it all was just a simple 6-state Markov model. This person had built it with 100 separate data tables. He was she was very, very clever, but it was utterly inappropriate levels of sophistication just to show me how clever they were. It's tempting, but we have to not do that. Okay. When thinking about a model, what's the story the model is trying to tell? Well, I think really we need to think about the natural history of the disease. When I say natural history, it's not necessarily the disease in the absence of treatment. Quite often it's what's the flow of the patient through the disease under the current care pathway, in essence. And we need to understand the disease in order to structure the model correctly. So we ask ourselves these sorts of questions. Do the health events happen over time? So is this a chronic condition? Do the risks of the events change over time? So my risk of a cardiovascular event is gradually creeping up at the moment. You know, I'm heaving in on 50. I've kept myself reasonably fit, but I'm starting to pick up some injuries, and so I can't do as much exercise. So I know personally my risk is starting to edge up. So it's not a constant risk. It's not the same as it was when I was 30. My risk of cancer is not the same as it was when I was 30. Lots of our health risks change over time. Is it important to capture that in a model? It depends upon what the decision is, the decision problem you've given yourself. Is the intervention equally effective over time? Or actually are there reasons to believe that it will become less effective as we age? Do we develop resistance to it, antibodies to a technology? A lot of the monoclonal antibodies we see coming out in cancer, there's a concern that actually the tumour cells actually develop some resistance. We see it in rheumatoid arthritis, the biologics for the rheumatoid arthritis as well, and in multiple sclerosis. So the longer you're on the technology, it may be you're less effective. Do you know the answer to that? Does your model allow you to capture that? Does the initial health change persist once the treatment stops? So you have a condition, you're treated, that puts you back in a health state. Do you need to then stay on that treatment? Or is this like a piece of surgery that puts you right and you're done? Or do you have to go back and get repeated surgeries? Understanding that, really quite central to being able to structure your model. And does the risk of the different health events depend upon your history up to that point? Once you've had a cardiovascular event, your risk of a future cardiovascular event is increased. Okay, so these are the sorts of questions we ask ourselves to understand the story of the clinical condition to enable us to structure the model. A couple of definitions. The first definition is the decision problem. The decision problem is the question we're seeking to answer. It involves at least two options, two comparisons, and at least one outcome on which to base the decision. Okay, so we need a decision rule that refers to an outcome. So cost per quality adjusted life year. The quality adjusted life year is the outcome that we might use to base our decision on. Ideally, we would want the decision problem to tell us which group of patients is affected. And often we'll also want to know what perspective the analysis. So looking at the costs and outcomes from the perspective of the healthcare system, the health payer, or the public sector. So we won't just want to know about the costs that are imposed on the health budget. What about on the educational budget, the social budget, welfare budget? Being explicit about the perspective is really important because you can't define all relevant costs until you've identified the perspective. Okay? So here's an example. Which method of operating on arthritic hips in young patients provides the best likelihood of a good recovery? Is it total hip arthroplasty or resurfacing arthroplasty? Okay? That's a reasonably clear decision problem. I would want to add from the perspective of the healthcare payer, probably. Okay? So, next definition, a decision node. This little square should be there. I did my presentation on a Mac, and sometimes when you move things from a Mac to a PC, things like this move, so I apologize, but so that little square's in the brackets there. That's the sign for a decision node. And you have lines coming from this, from a decision node, which identify what the options are. So we'd have two lines for the decision node here, one that's for total hip arthroplasty and one that's for resurfacing. There you go, there's our decision node. So we've got our comparators there. Now, a decision tree is drawn so that it can be read from left to right. So we start here and we've got a decision and we're going in this direction. We either go total hip or we go resurfacing. What we have are uncertain options, risky processes, and we capture these with what we call a chance node. It defines the risk and indicates what will happen as a result of it. For example, people may die of surgery. Everything can go perfectly except they have a bad reaction to the anaesthetic. They turned out not to be a good candidate for general anaesthesia, and they can die. All surgery has a usually very small, but nonetheless present risk of death. So, here we draw our tree, survive or die. Both of them have those two options, and we have some uncertainty about which way any individual will go. Transition probabilities identify the chance of each event occurring. And it's really important that those probabilities of the all possible events, when you sum all possible events probabilities, you should get to 1. So we've put some probabilities on. You've got a 99% chance of surviving and a 1% chance of death for total hip. Resurfacing, you've got a slightly lower probability of surviving, and hence a slightly higher probability of death. When we reach a node, a point where there is no more risk, we call this a terminal node. So we've got to the end of our pathway. In a tree, every risky process, every uncertain process has to arrive at a terminal node. And at the nodes, we define the payoffs. Okay? So here, what I've defined as a payoff, we have our terminal nodes. Our payoffs are the quality of life. So 0.8 for good function, 0.2 for poor function. So those who survive, not all who survive with good function. Some of them survive with poor function. And we still got our perioperative death, so that's a terminal node. Okay, so there we go, our payoffs. You get full health, good function of 0.8 probability, 0 times 0.2. So probability is 0.2. The value of that function, the payoff of poor function, is 0. Once we have a complete tree like that, we can calculate the expected payoffs, which we basically do by walking backwards along the tree. We read it out from right to left, and we solve it, in essence, by going from right to left rather than left to right. So our expected function, we have 0.8 times 1 plus 0.2 times 0. So we have the expected payoff is 0.8. So it goes in there. We make the same calculation for the lower one. Sorry, go back one. We can obviously finish rolling back. So we've got 0.99 probability of a 0.8 payoff. We get this plus 0.1 of a 0 payoff. So now we get our payoff, our expected payoff for the total hip arthroplasty is the 0.792. We've just rolled the numbers back. Okay, so that's a decision tree. And doing the same for the resurfacing, we get the expected value of the 0.8 of the resurfacing arthroplasty is better than the total hip, even though you have a slightly higher risk of death. So you've got a slightly higher risk of a catastrophic outcome, you might say. But the expected value is better on the resurfacing arthroplasty. And can we go back and see why we think that is? It's because if you do survive, you haven't got such a risk of a poor outcome. Okay, so that's what's driving that. Go forward. And you can represent it in a slightly different way, which, given the time, because we had a late start, I'll just flick that. You can check it when you get your copy of the slides. The thing about trees is they're designed to capture what happens at a point in time. They're really good for things with a short time horizon, hours, weeks. When you get into months, you may be struggling. So we say they're good for considering transitory things. So we have one, this is a model from a migraine treatment. And that's very short term, and a decision tree works just fine for that. The problem is, if you've got something that repeats often and has a long time horizon, a decision tree becomes unwieldy very, very quickly. So 3 options. If we had 3 nodes at the end of the first cycle, by the time we got to the 10th cycle, we've got nearly 60,000. That's not really tractable. That's going to make it really hard work for your computer to run. And just the risk of you making an error in coding your model, if there was only that reason not to do a decision tree, if everything else was fine, when you're trying to put that much information, decision trees, you're going to make a mistake because you're human. Well, maybe you won't. I know I make mistakes when I get that complex. So a Markov model is a really nice solution. We just have the 3 nodes and define them once. So Markov models, we define health in distinct states. They are mutually exclusive, so you can only be in one state at once, okay? You can't be healthy and sick. You can't be dead and sick. You're just healthy, sick, or dead, one or the other. And this covers everybody. We don't lose people. And you are in one of those states for a known and fixed length of time, what we call a cycle. It could be a day, a week, a month, a year. How long the cycle should be informed by how long it takes for a clinical change to exhibit and or how long it is between times at which the clinical care can be changed. So you may be in exactly the same health state, but your clinician may choose to change how they're treating you because they think another technology is better, safer, cheaper, whatever. So those two things together are what should determine your choice of cycle length, okay? It can't be arbitrary. You have to have a good reason for it because at every cycle you apply the evidence, okay? And the more times you apply the evidence, the more comparators will diverge. A little bit. You can have a one-day cycle to engineer differences. If you've got very similar technologies and you want to engineer an apparent difference, have very short cycles and lots of repetition. It will let you maximize the apparent difference. So the easiest way to identify the states is called an influence diagram. And basically it's a picture. It's a picture of a Markov model. And you just say, okay, so what states have I got? I've got well, diseased, and dead. What transitions? So with this disease, can people move from diseased back to well? Some conditions, you're never back in full health. You never return to full health. Whilst other conditions, we do. Or it takes you a long time. Normally, you'll be able to stay in that state for a cycle, and normally, you'll be able to make it from any state to dead. Okay? So drawing this influence diagram lets you identify the states and identify the logically possible transitions. And that's the first thing you do, really. So once you've talked to your clinicians and you've talked to the patients, you've got the understanding of that natural history story that we talked about, you then try and represent that in an influence diagram. Moving on from the diagrams, we read off them how long we need to follow the process for, how long do people stay in each state we then need to decide in consultation with the clinicians and based on the evidence about the natural history. How often people move between the states, which feeds into the how long a cycle should be. And then what are the costs and outcomes associated with each state? So here we haven't identified what the costs and the value of being in each of those states are. Okay, so we then have to layer on that information to put us in a position where we can build our Markov model. Transition probabilities are the key part. They're the engine of a Markov model, okay? Because they predict the rate of how people move from one state to another, whether they move very slowly or very rapidly between states. And they use conditional probabilities, conditional upon the state you are currently in time t. So if I'm currently well, I'm in well in time t, what's the probability of being in this dead state in t plus 1? So that's the transition probability there. So we can draw it on a modified tree, or we can place it in a matrix, a transition matrix. And this is what we do. Okay? So back to hip replacements. Hip replacements have a probability of failing in any given period. So we've got a really simple two-state model. Hip OK and hip failure. Okay? So we can draw a tree showing what might happen in the first 4 periods. So here's our influence diagram. 2 states, and you can either go from hip OK to hip failure, or you remain in hip failure, or you remain in hip OK. You can't move from failure back to OK in this model. So here's our decision tree. Period 1, and period 2, period 3. We could go on, and it would, as you can say, get very large very quickly. Or we can just represent it as a Markov tree. So something's a Markov tree when the diagram has this symbol at the front of it. Instead of that square decision node, it's a circle with an M to tell us this is a Markov tree. It tells us a Markov process is being known. And the chance nodes indicate where you start from, and the terminal nodes indicate not the payoff, because the payoff is associated with the state, but it shows the terminal node is where you're going to be in the next cycle. Okay? And we have an absorbing state. Okay, so HIP fails. An absorbing state is the state that you can't get out of. So dead is an absorbing state. And in this model, HIP fails, because we're not interested in reoperation and a new hip replacement, etc. We're just interested in modeling the survival rate of the hip transplant, the hip replacement transplant. Okay, so we have terminal nodes that now tell you where you're going to start the next cycle, and an absorbing state. And once all the patients have arrived in the absorbing state, that's your model finished. You've hit the time horizon. Now, strictly mathematically, in a Markov process, you will never get all of your patients into your absorbing state. So you have to choose a decision rule for ending it, for saying this is the time horizon, because otherwise we'd go on infinitely small portions a patient, because still not being in the absorbing state. So transition matrix is our probability of moving to the other state given where we start. So here's our transition matrix. We start in hip OK, 99% chance of remaining there and a 1% chance of hip failure. If you've started in hip failure, it's the absorbing state, so you're definitely going to stay in hip failure. Okay? And this is the engine. So I've already said this, but again, all the probabilities have to sum to 1. So the sum of the rows has to be 1, otherwise you're losing some people if it's less than 1. And if it's more than 1, you're gaining some people. Neither of these things are desirable in a cost-effectiveness model. I have seen them, though. Now, important thing to know about Markov models is they make an assumption, okay? And it's the Markovian assumption or the no memory assumption. Basically, it states that you use the same transition matrix every time. So if you are in a state, your probability of moving to another state is the same irrespective of where you were before. So if in fact your previous health affects your probability of a given event in the future, then you have to use a slightly different version of the Markov approach. So the strict Markovian assumption we call a Markov chain, where you just have one transition matrix. A Markov model is where you allow the transition matrix to be time dependent so that it can take account of what's happened previously. Okay? So generally, we use a cohort of patients. You don't have to, but normally we tend to use a cohort of patients. So everybody starts at the same age, and then everybody has the same age at any time point. Okay? And that makes it relatively easy to relax the Markovian assumption with a time-dependent transition matrix. If they don't all have the same age and you are simulating patients, it's a patient-level simulation model, then it gets a bit messier to deal with the non-constant risks, but it can be done. Okay. So once you've got your transition matrix, it's actually pretty mechanistic. You apply the transition matrix to the patient cohort repeatedly, and you can say if you're interested in getting the total budget impact of your technology, as well as its individual cost effectiveness, then you set the cohort to be the size of the population you're going to treat, and it will give you that information. But if you're not interested in total budget impact, then you can just put in one patient. You can have a cohort of 1. You will get exactly the same answer for the expected value. So it doesn't matter to the calculations at all. So to show you how it goes a little bit more, so here we have, we're starting with 10,000 patients. We've got that same transition matrix. So what do we get? We get our successes. We multiply the cohort by the probabilities, and that tells us what we have in cycle 2. And you just go on to cycle 3, Another thing that worked fine on my Mac, but I can see that logo in the corner is getting in the way now. So we'll go to there. You can see gradually your population, your cohort, moves from having an okay hip to hip failure. And when we plot that table, we get something called a Markov trace. Now, a Markov trace is just a graphical representation of that distribution of your cohort over all the states. And it's a really useful thing to plot. Not because when you've only got two things like this, but when you've got a lot going on, you know, two states, it doesn't really matter. But here's a 6-state model. This is really important, because what I can see here is my absorbing state of dead is getting there. If I've got to the end of my model time horizon and dead isn't accounting for the vast majority of the people, then something's going wrong in my model. Yeah? If I see traces that where I expect lots of people to be in that state early and move out of it to other states, but the trace went on this sort of pattern, then I could see if people are moving the wrong directions. And quite often, you know, a graphical representation of what your model is doing makes it so much easier to check that it's doing the right thing. Because staring at that table when it goes down 10,000 lines is really not very informative. I've personally checked that to be sure, and it wasn't. So Markov trace is a really good way. You just plot the columns of your transition matrix output, and it lets you see if your model is behaving as you expect it to do. So now the health warning. Please do not overinterpret findings. A model will paint a picture of a decision maker who is risk neutral. So how much uncertainty there is around this, models tend to say that if the expectation is the same, then the decision maker is indifferent. We know that in reality, decision makers are and should be more cautious about technologies that have high levels of risk associated with them. And there are mechanisms for analysing that quantitatively, but in the core kind of modelling approach, they tend to assume a decision maker is risk neutral. And the decision problem, often here, have you got that defined correctly? So we, in our simple model at the beginning of this, we had alive and dead. You can be alive in lots of states. So thinking critically about the states, because all clinically relevant states may not be all the states that are relevant to the patient in terms of their experience of that health. Okay? So when you look at the structure, if you look at the states, ask yourself always the question, are the values that the patients as well as the clinicians think we should represent captured in there? I think you need to be really careful. And those are specific examples of where economic evaluation is a tool. It doesn't give you the answer. It gives you a really useful piece of information. It synthesizes a certain set or subset of all of the evidence you'd want to take account of. There's always a gap between the evidence and the decision. And that's where the decision maker earns their pay, frankly. And it's very important as an analyst not to pretend that gap doesn't exist. And it's very important as a user of the results of economic evaluation to recognize that gap so that you can explicitly think about what's not there, what's not in the model that matters to this decision. Okay. Summary, we model because, well, no one study provides all the information we need to make informed decisions, so we have to bring all the information together from different places and synthesize it. And human beings can't process the volume of information required by most healthcare decisions, and so we model to reduce the risk of making mistakes. Decision trees are appropriate for simple processes that are transitory, But for longer term processes, we want Markov models for longer term conditions. And all models are wrong, but some are useful is kind of my motto whenever I'm talking about modeling. When you see the results of a model, you have to ask yourself, how is this model wrong, and does it matter? Okay, when you are building a model, every time you decide not to include something, you have to convince yourself that it wouldn't matter to the decision, or it wouldn't matter to the stakeholders in the decision process. Because if either of those are true, then you need to include it, because you will either get the wrong answer or you won't take the stakeholders in the decision process with you. So there's a judgment thing to be done there as analysts. We much prefer theory and empirical evidence than judgment, but unfortunately, if you're going to be an analyst doing modeling, you are going to have to make judgments, and you're going to have to own them and be able to justify them to the decision makers. Okay, I think that's it. Questions?